does the science actually say about gender-affirming care? Our moderator is Miles Lynch, who serves the Federal Trade Commission as one of our attorney advisors in the chairman's office.
Well, I guess it's not morning anymore, so good afternoon, everybody. I know we're running a little late right now, and you're all probably looking forward to lunch, so I won't give a long introductory spiel, but this panel is comprised of medical professionals who, building off of what we just heard from Dr. Lahl, can help us understand what the science really says about the benefits and the risks of gender-affirming care. First, I'd like to introduce, well, let them get seated first. Jennifer Lahl is the founder of the Center for Bioethics and Culture Network. A nonprofit organization educates the public, lawmakers, and others on bioethics issues. In this role, Lahl couples years of experience as a pediatric critical care nurse and a senior-level nursing manager with passion to speak on behalf of vulnerable populations. Lahl's writings have appeared in various publications, including the Cambridge University Press, the San Francisco Chronicle, and the American Journal of Bioethics. Her newest book, The Detransition Diaries, was published in 2024 and co-authored by Katie Fell. She's produced 11 documentary films, 3 of which examine gender-affirming care. Her films, Transmission, What's the Rush to Reassign Gender, The Detransition Diaries, Saving Our Sisters, and The Lost Boys, Searching for Manhood, were released in June 2021, September 2022, and January 2024, respectively. She's frequently interviewed by the media and has been called upon to speak alongside lawmakers and members of the scientific community, addressing issues such as human egg and womb trafficking. Next is Michelle Cretella. She's a pediatrician, writer, researcher, educator, and speaker. She's the past executive director of the American College of Pediatricians and the current chair of its Adolescent Sexuality Committee. She serves as a pediatric spokesperson and educator for the Association of American Physicians and Surgeons and the Catholic Medical Association. Dr. Cretella serves as a peer reviewer for the Journal of American Physicians and Surgeons, Issues in Law and Medicine, and the International Journal of Behavioral and Healthcare Research. She became a leading physician critic of pediatric transgender interventions following a 2017 interview with Tucker Carlson, in which she detailed their harmful effects and called them medical child abuse. Dr. Cretella received her medical degree from the University of Connecticut School of Medicine in 1994, completed her internship and residency in pediatrics at the Connecticut Children's Medical Center in Hartford, Connecticut in 1997, completed a fellowship in college health through the University of Virginia in 1999, and practiced pediatrics with a special interest in behavioral health from 1999 through 2012. At that point, she left clinical pediatric practice to devote more time to leading the American College of Pediatricians. Lauren Schwartz is a psychiatric and psychotherapist in private practice. She is board certified by the American Board of Psychiatry and Neurology, a fellow of the American Psychiatric Association, and a senior fellow at Do No Harm. Throughout her career, she's advocated for upholding the highest standards of care in medicine and mental health. Her recent advocacy centers on gender-affirming care, particularly on interventions she believes are unsubstantiated, such as puberty blockers, cross-sex hormones, and surgical procedures for minors and vulnerable adults. Her efforts have highlighted the critical importance of high-quality medical guidelines, and she asserts that low-quality evidence should never be authoritative as to what constitutes life-saving, evidence-based care. In 2024, Dr. Schwartz co-authored an open letter to the APA regarding its gender-affirming psychiatric care textbook, garnering over 7,200 signatures, including those of clinicians, educators, and researchers. She has actively testified against legislation that she understands compromise ethical medical practice and jeopardize vulnerable patients' well-being. Most recently, Dr. Schwartz collaborated with other medical and research professionals to publish an open access review. This review compiles over 50 studies highlighting extensive health risks associated with feminizing hormones in natal males. And finally, Patrick Lappert is a plastic and reconstructive surgeon who has been in practice for over 30 years. He is board certified as a general surgeon and has served as the U.S. Navy's Chief of Plastic and Reconstructive Surgery at the Portsmouth Naval Hospital. He also served as the reconstructive surgery specialty leader for the Surgeon General of the U.S. Navy. He founded the Pediatric Craniofacial Reconstructive Surgery Unit, as well as the Wound Care Center for the Portsmouth Naval Hospital, which was then the largest military hospital in the world. Dr. Lappert retired from the Navy after 24 years of service with the rank of captain. He then worked as a plastic surgeon in private practice for 18 years, recently retiring from the practice of medicine and surgery. Dr. Lappert has served as an expert witness in numerous legal cases concerning gender affirmation care in state and federal courts. He was active in the legislative process that produced Alabama's law protecting minors from affirmation care, and he has authored chapters in books about scientific evidence behind gender-affirming care, medicine, and surgery, and about the pastoral care of persons wounded by the gender affirmation industry. So if I can open up by asking Ms. Lahl, your question. Can you explain, I know we just heard a little bit from Dr. Lahl, what fertility preservation is?
I can actually read my remarks just so I can stay on task. Oh, sorry. Thank you. Very good. Yeah, fertility preservation is an assisted reproductive technology that is offered in an attempt to hopefully maybe preserve somebody's fertility so that they can have a biologically related child in the future. There's several different methods. One is you can freeze your eggs, oocytes, you can freeze sperm, you can freeze embryos, so you actually make embryos with egg and sperm and freeze them, or often as the case of pubescent children, you can do ovarian or testicular tissue cryopreservation. And that's an option that's available just to the pre-puberty kids because they don't have egg or sperm yet. Fertility preservation was first tried and used and perfected in the field of species that are at risk of going extinct. So it was a method that was used to try to preserve different kinds of species. Then it moved into the patient population of adult cancer patients where the therapy treatment they needed for their cancer treatment could negatively impact or harm or destroy their fertility. And then in the early 2000s, it actually moved into the pediatric cancer patient population so that children who also, are afflicted with cancer might have the ability to someday grow up and have a biologically related child. But now we've seen it expand into the scope of gender affirmation care as something that's offered. I'm probably the only person in the room that when the Cass review came out, the first thing I did was look to see what Dr. Cass said about fertility preservation. And I was saddened and a little bit shocked that she recommended in Section 10 that all children be offered fertility counseling and preservation prior to being put on a medical pathway. And if I could just sort of put a highlight under some things that Lior said, if we move to this assessment model, if we move to this model where we can do it better, we can do a good way of treating these children, and also if we trust the experts, who doesn't want to trust Dr. Hilary Cass, we have to be mindful of, I think, what I'm about to say, that maybe we don't want to offer this to children. As you said in my bio, I was a former pediatric critical care nurse, but for the last 20 years, I've been spending most of my energy in the whole area of fertility, infertility, and assisted reproductive technologies. I was deeply concerned as a nurse, as a filmmaker, when I learned that children who, before their puberty was blocked or before they were put on cross-sex hormones or offered surgeries, were offered fertility preservation as part of their care. And again, knowing that, the younger the child is, they're going to be offered the actual freezing cryopreservation of ovarian or testicular tissue in stage 2 to 3 Tanner stages where they have not yet developed mature gametes. It's one thing to provide the possibility of having a biological child for a cancer patient, adult or pediatric, who needs a treatment to potentially save their life. But it's a whole nother thing to offer a person who has healthy fertility, who we knowingly are going to damage, but we're going to offer them fertility preservation as part of their care. The research that Dr. Lahl cited on one of his slides that we published in March of 2025 in Frontiers in Endocrinology titled "Fertility Preservation, Is There a Model for Gender Dysphoric Youth?" We found only 2 reported live births in the pediatric patient, female patient, where ovarian tissue cryopreservation was done. Only 2 of those young women that were age 9 and 13 at the time of having their tissue frozen were able to successfully have a live birth. And one other case was reported in a 14-year-old female. It did not say whether or not she had been through puberty or not. But this young girl was able to, after 4 rounds of IVF, was able to finally give birth, have a live birth. But she did deliver prematurely, which is a risk of IVF pregnancies in general, to have premature deliveries. But in each of these 3 cases, all of these patients had to have a gonadotoxic therapy to treat their cancers for one of the reasons they were offered fertility preservation. As far as what we found in the male population, we found 0 reported success cases of young men that were offered the freezing of their testicular tissue. An important unknown for both of these categories is we do not know how many attempts were made. Like, so of the 3 young girls that were successful in having live births, did only 3 young girls attempt this, or did 3,000? We don't know. So you have to take that stat with a grain of salt. For those that have gone through puberty, so they were offered to fertility preserve their egg and or their sperm, this is no longer seen as experimental, but all of the data that we have is all lumped together. So these young people that, as part of their gender affirmation care, offered, accepted the banking of their egg and sperm, they're lumped in with people that are struggling with infertility. They're lumped in with the Silicon Valley women who are just freezing their eggs because they want to, have their biological clock, protected. But we do know of all these data points that are lumped together that overwhelmingly, per the CDC data, that over 50% of all IVF cycles fail. And I don't know what's going to happen with the CDC data, because the group that tracks all this at the CDC was let go as part of the DOGE, letting go of people. So we're not sure if we're going to continue to track this or if this is the end of the data that we're going to have. Embryo freezing, actually, in the CDC data shows the highest success in live birth. I mean, and the game is to get a live birth out of all this. It's the freezing of embryos, and we know in the gender youth population, they're not freezing embryos because they're not partnered with anybody yet. They just are freezing their own egg or their own sperm. Considering the gender dysphoric population, if they want to have a child, they also just need to consider the financial cost. I mean, it costs about $1,000 a year to freeze and store and bank your eggs. So if you're an 8-year-old and you're going to be freezing and banking and storing your eggs for 2 decades, you have to look at the financial cost. And we don't know in the medical literature for egg and sperm that have been frozen for that many years, what is the success rate for any of those ending up in either a conception, a creation of an embryo, let alone a live birth. We also have to consider the fact if this is, say, for example, a trans woman, a male who froze and banked their sperm, who then grows up and is partnered with a male. There's no egg in the couple. There's no uterus in the couple. So they're going to double down on the risks and the complications of a third-party conception rate. So it's evident to me, for all these reasons, that offering fertility preservation to the gender dysphoric population is deceptive. As the chairman said in his opening remarks, this is a misleading claim. I mean, when you are being offered fertility preservation, you think that you are preserving your fertility as in having a child, when in fact you're freezing your gametes with no guarantee whatsoever that you'll get a live birth. Thank you.
Thank you for that.